Welcome to the CME accredited video roundtable discussion titled Community Oncology Clinical Debates, Chronic Myeloid Leukemia. I'm Dr. Michael Deininger from the University of Utah Huntsman Cancer Institute, and I'm joined by Dr. Cherry Radich from the Fred Hutchinson Cancer Research Center in Seattle and Dr. Gail Robos from Weill Medical College of Cornell University in New York City. Welcome both of you, and thank you very much for joining me. Let's move on to the clinical debate number 2, and that is entitled, How should the relapsed refractory CML patient be treated? My first question is about relapse parameters. Which parameters do define a relapse in a patient with CML treated with tyrosine kinase inhibitors? Dr. Robos.
I think first you have to make sure what the initial response was. And that's something which frequently gets missed because a patient will come in and say, well, my counts were normal and now they're not. Were they really ever normal? What was the initial response to therapy? Because the point here is to define carefully what was the optimal response that was achieved with the previous therapy, hematologically, cytogenetically, and molecularly, and was that response actually lost?
If you imagine, following the patient that Gail's talking about, first you would have a molecular relapse going through the major molecular response level. We usually wouldn't change any therapy on that. Next, cytogenetic relapse. Clearly, if you have cytogenetic relapse, you change therapies. And hopefully you're not waiting to the point where they've undergone hematological relapse, because if that's the case, you haven't been monitoring them close enough.
Quick question, would you always repeat cytogenetics before you make a call, or is one result enough?
I think it depends on how bad it is. I mean, if it's 1 out of 20 metaphases, maybe, but clearly if it was 15 out of 20 metaphases, no, I believe that.
Thank you. So next question is about mutational analysis of BCR-ABL. Which role does that play in making a diagnosis of relapse or refractory disease? Cherry.
So once you have a relapse, the first thing you need to do is do mutational analysis, because that can help you pick what second-generation drug you use. So about half the patients will have some mutation in the ABL kinase domain, and there are various charts now that will let you look at the specific mutation and look and see whether one particular agent has much more efficacy predicted than others. These aren't perfect. There are some cases where dasatinib would be predicted to be, a very good agent and it won't work. There are some times when it would be predicted to be not a great agent and it does work. But in general, all things being equal, that mutation analysis can help you pick what tyrosine kinases to start off with.
Gail, do you follow patients without the context of a relapse with mutation analysis? Do you do that on a routine basis?
I don't do it on a routine basis. I think that the definitions have to be, if you're really having a relapse, you need to document via bone marrow biopsy. So we never make changes in therapy just based on FISH or just based on PCR. Do another marrow, really see that there is a relapse. At that point, even in the absence of accelerated or blast phase, even if it's just a loss of response to initial therapy, we do send for mutation analysis. And I think that they are helpful in picking therapy, but they're not perfect, as Jerry said.
Okay. One point I'd like to add is I think we should always question the patient whether he or she's compliant, try to figure out whether they're actually taking the drug.
Absolutely.
And then another point I'd like to make is with all the co-medications that people are on or the stuff they take, I always ask carefully whether anything of has been added by some other provider out there in the network.
Right.
Okay, well, once we've done that, we've established this is true relapse refractory disease. When do we actually make the call that imatinib, if the patient is on imatinib, should be stopped and we move on to a second-line agent, rather than, say, increasing the dose? Gail, maybe you want to take that question.
I think the only setting where increasing the dose of imatinib is really defined to be helpful is in patients who have previously done very well on it, who did have a complete cytogenetic response. Those patients, it might be worth it to increase the dose. More often than not, though, there is a switch then to one of the second-line agents, and again, the clinical characteristics are going to drive which drug to pick.
Cherry?
Yeah, I mean, I'm only going to be switching someone if they have had a cytogenetic relapse, or if you've waited too long and have a hematological relapse. Right now, we won't make any change in therapy just based on a change in their molecular response if they're still in a complete cytogenetic remission.
Right, but maybe you could elaborate a little bit on cytogenetics in general, because people don't like to do bone marrows anymore. But
yeah.
Is there any additional information you get out of doing cytogenetics that would sway
Sure.
you
Well, we talked
way?
about the additional cytogenetics, how important they are at diagnosis to identify other clonal abnormalities that are associated with accelerated phase and blast crisis. And the same goes in the context of relapse. If you have a patient whose disease responded and then is coming back up and has crossed the barrier where they'll have a cytogenetic relapse, the bone marrow is very important because some of those patients are in fact progressing into accelerated phase, right? Some of them are going into chronic phase, but some of them have made and jumped that gap into accelerated phase of blast crisis. Those are clearly patients who not only will you want them to try a second generation drug, but they need to be lined up for a transplant because it's likely that the second generation drugs aren't going to cure them. In the clinical trials that have been done so far with nilotinib and dasatinib, the median survival for people who have gone into accelerated phase and blast crisis is less than a year. So those are people you really have to pay attention to.
So Gail, any comments on people who develop cytogenetic evolution on treatment?
Well, it's not necessarily the case that picking up, for example, a trisomy 8 or there are other abnormalities that have been shown to pop up in patients who are in chronic phase, who are doing well on their therapy. It's not absolutely indicated to make a switch in therapy just on the basis of picking up another clonal cytogenetic abnormality. However, you do raise an eyebrow when that happens, and if you're going to monitor those patients quite carefully. We certainly have some with, for example, trisomy 8 on whom no therapeutic change is indicated, but if you also have subsequent rising of BCR-ABL transcripts, you're probably going to do another marrow and you're going to monitor that patient very closely.
Once we've established that a patient has relapsed and maybe he's even marched through a second-line agent, so the question is what comes next in terms of investigational therapies? Is there anything on the horizon that is particularly persuasive? Maybe Cherry, you want to start?
Well, the first thing I have to add is, I'm putting on my transplant hat, is that if I could get these patients to transplant, I would certainly get them to transplant. And there are a number of investigational transplant strategies now, and we like to say really that virtually every patient has a donor now. If you look at relateds, unrelateds, haplos, and cords. So if someone is marching into accelerated phase and blast crisis or is in chronic phase and have blown through their second generation drugs, that should at least be considered. But nonetheless, other agents, ponatinib is probably the most interesting tyrosine kinase. It's effective actually in all phases, and it's particularly effective in the 359 mutation, where none of these other agents that are out there right now are available. And in the last trial, about almost 80–90% of patients treated with ponatinib who had a 359 mutation who were in chronic phase got a complete cytogenetic response, which is really quite shocking. And there's going to be a new trial of that agent versus imatinib in frontline therapy. So I think it's a really promising agent.
So Gail, any thoughts on ponatinib from your perspective?
Well, certainly the data up front are very impressive. I think that as with everything in oncology, when it's working in the absolutely most difficult patients, the question is if you put it up front, is it going to be better than what we have currently? We have some really hard numbers to beat because frontline therapy is very effective, but I think that it's going to be a player clearly, hopefully soon, so that we can have it be available. But I think your point before is the important one. Marching on to accelerated or blast phase is marching on to death. Those patients unfortunately die of their disease. So the question should be that if there's any suspicion at all that the disease is going in the wrong direction, to very early jump in and get that transplant evaluation going, because although donors are available, you can't necessarily get one in 2 weeks. So if you need to cancel the transplant, you can always do that, but you need to do the workup.
So transplant remains on the horizon. Now let's move on to the case study. So that is now about a patient who is relapsed refractory. Just to give you the history, that's a 49-year-old man with CML, on imatinib 400 for 7 years, diagnosed in chronic phase, achieved a CCR after 6 months, so really fast response. And now his PCR levels on the international scale have fluctuated somewhere between 0.09% and 0.4%. But now the most recent tests showed a very significant increase to 5.6%. He's got some comorbidities, diabetes, polyarthritis, depression, and so he's managed by several different specialists. He's currently asymptomatic and his physical exam is negative. So a thorough history reveals no evidence for non-compliance and there was no recent change in his co-mats. The repeat PCR that you sent for reveals a level of 7.2%. So he's asymptomatic, physical exam is negative. What are you going to do with that?
So the next thing to do is a bone marrow. We're going to do a bone marrow aspirate and biopsy and check cytogenetics and see whether we can confirm that he has actually had a cytogenetic relapse. And if that is the case, also do a mutation analysis at that point.
Yeah, I think that's exactly right. And the other thing that will drive what we do as far as the second generation choice. And then the other thing I think you have to consider is once you start the second generation, how long do you give it until you call off the dogs and decide you have to do something else like a transplant?
So any kind of guideline?
Well,
for that?
There's two guidelines, one from MD Anderson and one from the Hammersmith. The MD Anderson looked at people who were treated for 12 months and looked at people who had at least a major cytogenetic response. Those people they would keep on therapy. Those who had less than that, they would switch to transplant. The Hammersmith does it after 3 months. At the Hammersmith, if you haven't had at least a minor cytogenetic response after 3 months, they would go to transplant. From a practical standpoint, that's a pretty good fit with getting donors ready because the average time to getting an unrelated donor at least is 3 to 4 months. So in our neck of the woods, we take a patient like this, switch them to a second generation tyrosine kinase, start the unrelated donor search, presuming they didn't have a family member, and then at the 4-month mark, when someone says we've got a donor, reevaluate them. If they've had a good response, we keep going. If they haven't, we just go to transplant right then.
I think in this particular case, the question also was a little bit loaded in that there were medical comorbidities indicated.
Right.
And I guess there you really have to see, well, how bad are they? Is this just diabetes or is this a brittle diabetic who's had major complications? I think that's going to drive, if you really are getting to the point of picking between a pretty good response to a second generation agent and a transplant, I think what may drive that decision is what would be the predicted risk of transplant given the various scoring systems for medical comorbidities that we don't have enough detail on this case.
So now I want to ask you a loaded question. Once you made the 3-month call that somebody has to go to transplant, but then it takes up quite a bit of time to ramp up to the transplant. And you do another bone marrow at 6 months. And the response has miraculously improved. Do you proceed to transplant or do you just say, well, he's doing well now, let's just keep on the drug?
I'm sitting next to a transplant.
I would actually, if they've miraculously improved, how miraculous and how much improvement?
Okay, so let's construct a scenario. So no cytogenetic response at 3 months, but a major response at 6 months.
Oh, see, well, I would probably be patient. And in this case, I'm very comfortable in following PCR in this case. And if the PCR in the peripheral blood the next month was still going down, I would probably treat like people do with myelomas, go to basically the plateau response, right? If it keeps going down, I'm willing to follow. If it plateaus or comes back up and I've got the donor ready, then I'm probably going to pull the trigger.
Would you agree with that?
I mean, I have to say that I don't love sending people into transplant. There is still, you know, no matter how good the donor is and how good the transplantation facility is, how good the transplanter is, Jerry, it's still 15, 20, 22% mortalities. That said, if you have a young patient who is perhaps under 40, who has a really good option for a donor, I think it's very stressful to have ongoing monitoring with your miraculous response, because what if that miraculous response is then lost 3 months later? And it might be easier to just do the transplant. If they're an older patient than that, or if there are hitches with the donor, I would definitely go on.
What about patients with that dreadful T359 mutation, Jerry? Young patient, 25.
Get them ponatinib first.
Yeah.
If they don't respond to complete cytogenetic response, then go to transplant.
Thank you very much for joining our clinical debates on chronic myeloid leukemia.
Thank you.
Gail, Jerry, thank you so much. It was a great debate.
Thanks.
And hope to meet you again.
Thank you.